Yes, and recording has started. Should be good to go. And here we are. Okay. So I think let me just turn this on just in case. So this chapter again, this is about the X-ray film and how we use to process it and what is it made of and all of good stuff. So at the beginning, we need to know um, definitely, again, as we said, we need to know more about that. And we'll talk about the intraoral film and the extraoral film. You know the difference. The intraoral film is what you guys are taking now in the lab most of the time. I think all of the time, right? It's inside of the mouth. It's the periapical, the bite wings, right? The occlusal films. And then the extraoral films will be the panoramic machine, which I'm not sure if it's in this semester or the next one, but definitely going to take. So, and this is about the, again, not the digital one, the regular film that you guys are not using. So we start with the extra for oral film because it's a little bit more easy to go through. It has kind of less information, and then we're going to go into the intraoral film, and then we'll know how to process a film because it applies to both extraoral and intraoral. So we know definitely the extraoral film is larger outside of the mouth. The main thing about it, again, you might have seen or not, the extraoral film actually need to be placed in a cassette, something similar to that, and that cassette needs to have these types of what we call intensifying screens. So these are kind of layers that would help to produce the actual image inside of the film. So it doesn't work technically. The extraoral film does not work as similar to the regular intraoral film. So the extraoral film is considered as a screen film, and it's more sensitive to fluorescent light than to, huh? I cannot hear. Than to radiation. So the majority of the image that we get on an extraoral film is taken because of the fluorescent light. And that is what the intensifying screen does, actually. The intensifying screen would transfer the X ray radiology energy to a visible light, technically, which is the fluorescent light. So it has a mechanism inside of it. So when the film get hit by X-ray, technically the X-ray would hit the intensifying screens, right? Which are these, the white stuff. And then we have the film inside of here. And then the intensifying screens technically will produce visible light that will hit the film. We'll talk a little bit more about that when we get to that point, when we talk about the extraoral radiology. We might talk a little bit more in depth about it. But generally, that's the idea. We have a cassette that has intensifying screens, and these intensifying screens would transform the lights, the X-ray to a light, and the film itself, the extraoral film itself, is a screen film that is more sensitive to fluorescent light than the regular. So image will be produced some by X-ray, but mostly by the fluorescent light. So combine both of these, that's how we will get the image. It comes in different sizes, mainly two sizes that we have. One for, huh? Extraoral. Extraoral bite wings. What do you guys? Any of you have you know braces or done any? Huh? Yeah. So what did they take? They took a bigger panoramic X-ray, right? Pano. So this is like a panoramic one, and this one is cephalometric, which is technically the side of the face. Usually they take this. They can take this in orthodontics, but not as often. And also when we are doing like maxillofacial surgery, then they will take that. Anyway, Well, you bite on a bite block just to keep holding in place. You're not really biting on the X-ray. The X-ray is outside of them, but that's the extraoral one, which is the panoramic or even the cephalometer. It can be both. Yeah, it's just, huh? Every time? Yeah, sometimes they do these. If they're digital, some would say that they would give you less exposure than exposing you to, periapical and bite wings. But honestly, a lot of times it's because of insurance, as far as I know. Like they would get more money for exposing, because you get usually, I think you get every 12 months you get to be exposed to, or you have the allowance, from your insurance to be exposed to a panoramic X-ray. If it's with the orthodontics for an orthodontic purpose described by the dentist, yes, they should take it, but not for just a regular thing. Even Yeah, it's we should not take X-rays unless they are really needed. Even the regular 6-month visit, technically, we should have a prescription. If the dentist see that your teeth are good, you don't have any cavities, they know that you're taking care of your teeth. They should not prescribe even the regular X-rays for you. Technically, right? To again, there's much less now exposure with digital and everything, but the actual recommendation is that we do not take X-rays unless they're actually needed, not just because we want to do checkup. Okay. So again, these extraoral films can come in, as you can see here, flexible cassettes or rigid cassette. Again, most probably nowadays, most of offices would not have the manual films, so it's digital most of the time. But anyway, again, this is just to know the digital film will look like the cassette, but definitely, I mean, we cannot open it or put a film in it or anything like that. How big? The film, as big as the compu- the cassette itself. Like you see this guy holding it, so it can be as big as that. Like as big as the panoramic can be, yeah, as big as the keyboard almost, and the cephalometric is more like the book size almost, something like that. Yeah, they're bigger. Yeah. Okay, we're good with the extraoral film. Now let's talk about the intraoral. So again, just know the general information. It's a screen film. It needs a cassette intensifying screen that changes the radiation to visible light, and that's how we get the X-ray. Okay, the intraoral film. So the intraoral film, again, this is just keep in mind we're not talking about digital. We're talking about the regular film. So these have emulsion, which we'll talk about. And this is technically how it will produce the X-ray image, but also it has speeds, what we call speed. And technically speed mean how sensitive they are to radiation. So how much X-ray we need so we can get an actual good density on the film. So they used to have, again, speeds. The faster the speed, whoops, wrong. The faster the speed, the more radiation required? Well, I'm just asking. Right? It's a fast film. You don't need to expose it much, right? So if it's again a faster film, and that's what we want. We want to get faster films to expose the patients less to radiation. So it uses letters. Guess which one is faster? So it goes from A, B, C, D, E, F. But I mean, it has A, B, C, D, E, F. So A is faster. Who agrees? No one? No. because that's how they started. They started with the A film and it was slow, and then they, figured out a better technology, and now they have B, and then they C, and then D is F is the fastest. D is still acceptable to be used, and you might see it in offices again if they're using manual at all. And technically, the speed just correlates to how big the particles into the film. So the bigger the particles, the faster it is. But again, if you have bigger particles, then you have less sharpness. So you have to have like a good measure between these. Anyway, F is the faster, and it's the way that they made them. Just A is, I don't know, huh? The speed. That's the speed. Yeah, that's the speed. So use letters for the speed. We're talking about the speed here. Yeah. So the way that they agreed on, I don't know if there's a backstory for it specifically for using letters, but the way that they agreed on, they said we're going to use letters for the speed of the film, for how much sensitive they are. Yeah, A is less sensitive. That's the way it started, and then they reached to F. And again, most probably, if we continued with manual films, we'll get more letters and faster speeds and less exposure. But now with the digital, we have all of that. All good? Okay. Sizes, we know we have 5 sizes from 0 to 4. 4 is the occlusal for adults. 2 is the, what do you call it? We call that standard size, right? I mean, we talked about this in the first lectures. 1 is usually the pediatric one that we use. Yeah. The larger the number, the larger the size of the film regularly. And we know these are technically how the films, most probably you only see 2 and 1. Rarely you'll see 4 used, because again, that's the occlusal. It's only if a surgeon is working with. And why we use occlusals? To see what? Yeah, the palate or the what? Not the bite, but yeah, the floor or the roof of the mouth. So, like for example, if we have a tooth that is embedded in the palate, which happens, right? Some teeth would not erupt, especially the canine, for example. So if it's embedded in the palate and you want to locate it, the dentist want to locate it to be able to open it up and pull it back in occlusion, they might take an occlusal x-ray. Or if they want to see sometimes a tori on the mandible and how much it extends, they might take it. Again, with a pano, it's kind of covering that anymore, most of the time. But some dentists might prefer occlusal just because. Size 4 is occlusal, yeah, for adults. And we can use 2 for kids as an occlusal. So if it's a pediatric, if it's a child, we can use 2 for them as occlusal. But for adults, it's 4. Any questions about that? No. Film storage and protection. I thought this should be at the end, but anyway. Film is sensitive to radiation. Right. I don't need to read that for you. Okay, this is how the X-ray film looked like in person. Have you guys seen it and touched it in your hand in the lab? Yeah? Okay. So you see, this is the film. We know that we have that dot, right? That would help us with what? Yes, orientation. And you can see, usually on the back of the film, you'll see that it says the opposite side is towards the tube. So usually the white or clear color side, that is the place where we're going to expose the X-ray. So just a way for us to know this is where the tube would be facing. And here, what is the speed? E, yes. So usually the right? Not so fast, but still, not the fastest. So usually the speed is written also on the back of the X-ray film, so you know what it is. And sometimes if it contains 2 films inside, sometimes they would put, actually, instead of putting 1 film, they would put 2. So you can give the patient 1 and keep 1 for your records. they would also put it's a duplicate film. You know, again, that's used to be a problem. You have to duplicate a film for a patient, and we have a duplicator, you know, that we duplicate films with. But now with digital, everything is you just send it to them. Anyway, but again, we just need to learn these things to know our how much better things are. This is the film when we did you guys open it? No, you did not open it. So I'll see if we have enough of these to give you guys in the lab. Maybe I'll see with Dr. Espina, just so you can open it yourself and see. When you open it up, you will see different things inside of it, and we'll talk about each one of these things and what are used for. Da, 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 da. Starting with number one. These are relating to the picture that I have here on the side. Okay. So number one is the huh? How did you get that? Moisture resistant outer wrap. So that is the soft vinyl plastic, you know, that the cover and protects from and 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 huh? And 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 lights, right? We don't want so it protects from light and moisture, yes. Because right, that's the main problem with digital, well, with regular films. If it's exposed to light, then that's it, right? So this is one layer of light protection. Has a front side, which is the what the tube side, which is solid white, right? That's what I was saying, right? The solid white is the tube side. This side is the tube side. Okay, and the back side, white, yeah, and the back side that is white or colored, usually colored. Okay, all good. This is number one that you see on the picture here to the side. This is the back of it, and this is the opening of it here on the other side. Okay, now we're talking about number two. Guess what number two is? Now nobody's trying to guess. A black paper wrap, and it's for light protection. I should have asked you about this. So this is just another layer, addition layer to protect from any light leaks that might happen, before as you're opening it or before, as you're using it, at least you're not losing the x-ray, even if it has some, puncture or whatever tear and on the outer wrap. At least you have the paper wrap on the inside that will help with protecting the x-ray film. Okay, now number three. Well, I think we'll jump to something about this. The identification dot. Well, number three. Let's see. What is number three? Huh? Yes, film. That is the actual film. That's how it looks like, right? Again, we need to get you guys to open one of these, so you can see them with your hand and recognize better. So it can contain one or two, as I was saying, for duplication, right? Again, for previously, this might be much easier to duplicate if the patient needed a copy for themselves. And it has, yeah, yes, Kara, yes, a raised identification dot. So now let's talk about how this identification dot helped us in the past and how we have now in the digital x-ray. Usually we have a letter on the bottom on a corner that would help us in the same way. So the raised dot, you see it here, we saw it in here, and then same thing here. This is a person, right? You can, and he's looking at the patient. So the dots usually should face what? The X-ray tube, right? The convexity of the dot, the raised portion of the dot, right? Because it has a raised portion and it has a concave portion, right? If you look at it here, you'll see that we have a raised portion that is on the tube face, and then it has a concave, or, you know, an inside portion that definitely this should not, huh? On the other side, right? So the raised portion should be facing the tube. That's an important thing, one thing to help us not to place it incorrectly inside patient mount, not to place it backwards. And it helps with the orientation again. So we know that, again, it's not backwards placed, it's forward placed. This is where the tube head should be. And it can distinguish between, that is an easy one, sides of the x-ray. So how does that work? I think I did explain about it, but I want to explain a little bit more. It helps with the left and right. Again, it can be letter as well. So an important part of that, especially happen with the bite wings. So if we have a bite wing here, as you can see, do you see where the dot is on your computer? I'm not sure if it's on the left here, right? So we have a dot here. And we agreed all in the office that anytime we take an x-ray, we will place the dots. We will place the dots on the mandible. Okay? So I took a picture of here. What side is that of the patient? Right side. Yes. That is the right side. And then I took another picture here and I kept it on the mandible, right? The dot is on the mandible. And then I took a picture here. I kept it on the mandible, right? And then I took a picture here and I kept it on the mandible. Once we took the pictures out, right, and we want to organize them, I just placed that dot with the raised portion towards me on the bottom side like that. And then this will just tell me right away that this is the right and this is the left, because I kept it in the same place throughout my x-ray. And this told me that, well, this is my right side and this is my left side. Because on the right side here, it will be close to what? To the premolars, right? Between the premolars and the molars. They're close to the mesial of the patient, right? Going mesially towards the middle. While on the left side of the patient, it actually away, so distal from the midline of the patient, right? Does that make sense at all? Yes? Okay. I guess you just want me to continue, even it does. No, I'm just okay. So you can see here again the placement. So this is something that we used to teach again. Although again, same thing when you use the ones that have the letter on them. So it'd be the dot in the slot. This is the, what is that? Holder, right? That's for which one? The bite block for which X-ray? For posterior, right? Posterior periapical, the yellow one. So anyway, that's the slot that you slide. Oh, you guys haven't used these yet, but anyway, you'll see with the phosphorus plates, the thin ones, you have a slot that you need to slide the X-ray in. So we always say the dot is in the slot and the white is in sight. So white in sight means you will expose the white side of the film, because that's the tube, right? That's the tube side. And then the dot is in the slot, so you always make sure that your dot is in the same location. Does that make sense? Yes? Huh? No? A little bit? Huh? You always put the dot in the slot, so you're not putting it upwards, right? So this gives us a systemic. You're always placing it in the slot, which is usually would be the occlusal surface of the teeth, right? So the dot is always lined up. So if these are the teeth, for example, we have a molar here, right? Right? It's with the occlusal surface of the teeth usually. Even if it's a mandible, same thing. It will always be with the occlusal, because if you place the dot here and then we have a periapical abscess or problem, then it can cover it. It can cover it. Anyway, we don't need to go too much in depth. I mean, you guys know now. It's helpful with the orientation and with the left and right sides of the patient. So again, taking a look at these, placing it always in the same direction would help us with the left and right. All good? I guess. So continuing with the packet, with the film packet, that's what it's called, right? Having all of these things in it. So we talked about 1, the outer, 2, the paper wrap, and 3, the film. And number 4 is, I guess you guys don't know that. Well, doesn't it look like it's a metal-ish? Foil, yes, lead foil. Yep, that is a lead foil. So each film has a small lead foil at the end or at the back of it, right? So it's in the back of the film. And guess what is the use of that? So again, this is the area that is not exposed, correct? You know, when we expose the film, this is the back of the film. So it's located, the lead foil is, again, see, located here on the back, not on the front, because we exposed that. And we know lead would not allow radiation to pass through, correct? It would prevent the radiation from passing. So why would we place a lead foil at the end of the film? Right. So that is one thing. So stops it from going inside, technically, and more also to absorb the scattered, yes, scattered radiation that comes from the back. So I'll show you. And it reduce fogging by doing so. Fogging of the film. So I'll show you in a minute. We got this? Scattered and fogging. So if we are taking an x-ray here with this tooth, right? And we hit the x-ray here, right? It will get our radiation, but some of the radiation will go there and it will go back where? Into our film. So to protect the film from getting these radiation that is scattered from different locations and going back to hit the film, we have that lead um, foil. Thank you. Good job. The lead foil, right? Exactly. And now an interesting thing happened when you actually place the film wrong, right? On the wrong side. So if you place the film with this foil facing the tube head, we will have that pattern that is called a herringbone pattern. You see this? You see this pattern here? Yeah, that's a herringbone pattern. And this is technically telling us that, well, you hit your x-ray wrong. You placed your x-ray wrong. Okay? So this is an operator error. When we used to do that, you know, if someone was maybe in a hurry or something, like they would place it wrong and then take an x-ray. You still can't see it, but again, it shows that there. So shows a pattern. What is this long word? Backwards. This pattern. I guess this was not meant to be read. It was done by mistake. It was only the herringbone. And if you look for herringbone pattern, you'll see that's the pattern. Like it's a pattern. You know, you can buy things with a herringbone pattern on them. Okay. So this what will that show us if we place it by mistake. So I think now we got we covered all of the parts of the X-ray film, from the package to the paper to the film itself, and then to the lead foil at the end. All good? All good. Now we're going to talk about what's inside of this film that will actually cause the X-ray to appear. What will make exposing a film to radiation be able to show us an image on that film? Okay, let's take a look. So now we're talking about the actual film. So the film out of the package, this is what it has. So technically it has two parts. It has the film base and it have the emulsion on it. And that's the film base here. You can see it. And that's the emulsion here on top of it. So the emulsion is technically attached to the film by an adhesive. That makes sense, right? That's the emulsion and that's the film, and they are attached by an adhesive. Okay. So the film base itself, it is just for supporting, mainly supporting and having more strength so we can use the X-ray film, manipulate it. And it usually has a, huh? Huh? What's that? Someone said blue. Yes. It has a blue tint to it. So if you get a film that is not exposed at all, was not hit by X-ray, and you process the film and you take it out, you will see it looks like a blue plastic, technically, a blue tinted, again, like a plastic thing. And then the emulsion is attached by a thin adhesion to the film base. So what do we have here in that emulsion? This is what actually makes the X-ray appear. This is what actually reacts to the exposure of the X-ray. So it has crystals of silver halide, right? Yes, suspended in gelatin. That gelatin will swell when we put it in the developing solutions, which we'll talk about in a second. And this would cause these crystals to be exposed to the developing solutions. And then afterwards, that gelatin would shrink and dries, and it will protect it. So everything, I'm sure you didn't connect to much of what I've said. But anyway, so I'm just saying that now, again, we have the film base, right? And the film base, attaches, or an emulsion is attaches to the film base by an adhesive, right? That emulsion has what it takes to make an X-ray, okay? The emulsion has two parts in it: the gelatin part that holds everything together, and the silver crystals that actually will get exposed to the X-ray and make the film. Okay? So far, so good? Yeah, so these gelatin and the silver is what makes the emulsion. Okay? Let's see how this will work. The latent image formation. So technically, when we say latent image, we mean an invisible image on the film. So when you expose an X-ray, before you develop it, before you, again, I think you might not be able to relate as much because you're using the digital. You take an X-ray and it shows on the computer right away, right? But again, in the film, we used to take the X-ray and then we have to take that, we expose the X-ray. We have to take that X-ray, put it in processing solutions to be able to see the actual X-ray, just like the photographs before, right? When they use, huh? Right, exactly, in a way. So they take a picture, but the picture would not appear before they have to process it in different chemicals, and that's when you get the actual picture. So before the actual real picture would appear, there is still a latent image, an invisible image on that Polaroid, for example, film, right? So that's what the latent image is. Again, similar to what we have here in the X-ray. So what happens here when we expose that X-ray? So when we do an exposure, where's my mouse? when we exposure, the X-ray would hit some of these. Yes. Okay. Then you guys are, you know what you're talking about. That's good. I didn't lose you that much. That's, yeah. So, right. Because we know these silvers are there. We took we're exposing an X-ray and when hit these silvers. So what happens with these crystals, they would separate into different components, which are technically some ions and silver. And this what will create the latent image. So if you look at the picture here, number A is the film that is not exposed at all. We have not exposed the film yet. Number B is when we exposed it, and you can see that some of these crystals got exposed, right? And some of them did not. And that's what actually created the latent image that is still on the film. And then when we put it in the developer, we have the ones that are exposed to turn black and the ones that are not exposed just to remain as the same. And then we have a fixer that will erase all of the other ones that are not exposed and keep the exposed one only on the film. Does that make any sense? That's good, right? So this is before exposure. A lot of these crystals are just still in place in the emulsion, right? When we expose it, some crystals, will have the latent image. Then we have these two chemicals that we'll talk about in a minute that we call developer and fixer. The developer will convert or develop these exposed crystals into solid grains of silver that is black, right? Because when the X-ray hit the film, it will turn what? Black, right? The parts that are not hit by X-ray are the ones that are gray and the ones that are white. Correct? Yes. If you just had a film and you expose it directly, it will appear all dark, right? All black. So that's why, again, only the ones that are exposed by the X-ray will turn black. And then when we use the fixer, it will clean them up and only removes the image. Only keeps the image. So let's see here. Latent image, that's how it was made. And then the chemical processing will transfer the latent image into visible image, right? This is where we can see the actual picture. And definitely, as I was saying, depending on the thicknesses of the objects that the X-ray will hit, that's how much we will have crystals that got exposed. So, the soft tissue will not stop the X-ray, so it will hit the film and it will make it dark because we got all these crystals to be exposed. While, for example, the tooth, when the X-ray hit the tooth, it cannot pass through the tooth, and it will not expose these crystals, and then these crystals will not turn dark. Does that make sense? Yes, and that's how, again, that's why the film parts that are, or the soft tissue parts of the film would appear dark because, again, they would not stop the X-ray, and the X-ray would hit the crystals, and when the crystals are hit, they will turn dark technically. Anyway, that's another picture explaining the same process. So that's when the X-ray hits the crystals, forming the latent image, and then the developer would make them black, and then the fixer would clean up all of the unexposed crystals, and then will only leave the image for us. Okay, I think it's time for a video. I didn't find good enough video, but I think it's okay. It's an okay video to see. Let's see. Is it that one or this one? As I go through. Skip. And Dr. Joshi from SPRMES. And no, not this one. Sorry. Students with ADHD say. Okay. Let's see, is it this one?
In advance.
So this is what we used to have to do when we take an x-ray. We have to have a fixer, a developer, a washing solution, all ready to be able to actually get the x-ray to be developed. So I'm just showing you the pain that you're not going through because we have digital x-rays.
Prepare the solutions in advance. Always follow the instructions listed on the packing. To achieve the correct ratio, use a graduated cylinder. For storage of the solutions, use the closable light-type containers.
Anyway, she prepares these.
To avoid confusion.
Let's see, and she put them in these containers that has fixer and developer.
Always follow the instructions.
Huh? Yeah. Exactly.
On the packing.
I mean, technically, it has to be in red lights, you know.
Always check the temperature of the solutions and the prescribed times before you start the processing. Other operations are all ready to be realized under safe light in the dark room. Is educational. Your daylight.
Not sure what's going on. I don't think it's me. Someone at home.
Close the containers between each use, thus avoiding oxidation and drying.
So you can see you put it first in the fix in the developer, then you have to technically wash it.
Contact with the container.
I mean, rinse it.
Must be immersed in the liquid completely.
And then you put it in the fixer afterwards. And then you put in the washing solution.
After using the solutions, rinse the picture carefully with water. Let the image dry carefully. Change the washing water according to the need and degree of pollution. Close the solution containers carefully. After drying, pass the picture to the doctor for further diagnostics.
Boom, and we get an x-ray. So that's the older way, the manual type of processing, again, having to pass through all of these liquids and prepare them. Afterwards, they developed something called the automatic processor, where you put the x-ray and it passes through the tanks automatically, and it comes out complete. But again, you have to clean up the tanks, you have to fill up the chemicals and all of that, these things that you have to do. So still, we're really good with that, with not having that. Okay, let's see where we are. So we have the solutions or the chemicals. We have the steps. Sorry, the steps for the processing. You have developing, rinsing, fixing, washing, and then drying. So for the developing, you use the developer chemical. So it will reduce the chemicals to black, metallic, silver, and then rinsing would remove as much developer as possible. Like we saw, she's passing through these uh, tanks, and then fixing using the fixer would stop any further developing of the film, would remove and dissolve any, yes, unexposed or undeveloped crystals, and it will harden the emulsion to establish the image. Zoom in, yes. Okay. And then washing would remove any remaining traces of these chemicals, and then you can do the drying. And these are kind of similar to the chemicals that we used to have again. And these are more for the processor, the automatic processor. Anyway, but these are the chemicals. So moving on, as I was saying, there are different types. We can do it either manually or automatically. We used to have a mini darkroom box. You can see if you zoom in a little bit closer. Um, Again, because X-rays are sensitive to normal lights, to blue light, technically we'll cover it. We have to have a cover or a safe light that is red that we can work in without getting the X-rays to be ruined. So that's why we can put a box that has that filter on top of it, and you can see they have four cups. One is fixer, one is rinse, one is developer, and then one is wash. So that's how you used to do it. Chair side, so first cup is developer, then rinse, then fixer, then wash. But again, thankfully, we're not doing this anymore. Then we had the automatic processor. So this is much faster. This is how it looked like. We used to have one in the lab, but because we're not using it, we actually removed it. This is where you put the films. You put your X-rays from here, and they will go through 3 tanks, and then they come up from here. The 3 tanks are like that. You see here. This is where we put the film. This is all inside of the machine, and we have these rollers that you see here that we had to remove and clean up. It was just a lot of work. So you put the film here. It will go through the developing solution and then goes up to the fixing solution, and then goes up to the wash, and then goes up to drying. And then you have a warm X-rays coming out of the oven right when you need it. So, and these are the rollers again. It's just a lot of interlinked rollers that will move these through and get them through. This was the automatic processor. So I want you guys to know what tanks that we have in here for the automatic processor. And again, the same steps for the manual. I mean, you have to go through developing. Here, you don't have rinsing because most of the extra developing solution will be squeezed out by these rollers. So we don't have like a rinsing in between. We have a fixer, and then we have wash. Okay. Fast. Which, well, yeah, mainly knowing the tanks, what's inside of the tanks. Yeah, yeah, you don't have to. This is just a real picture of it. Yeah. So it will regulate temperature and time again, because with manual one, we used to have to think about, well, we have to put it 10 minutes and then remove it and put it in another cup and then remove it. And then, it's just the process, the whole thing. Have regulates temperature and everything. It has disadvantages, definitely, because it can malfunction, a lot of maintenance, and then we have a lot of depletion of the chemicals. Anyway, that's all good, right? So consists of these swelling tanks. You guys know what? Yeah, it's not coming up. A is developer, B is fixer, and C is water, and then the drying chamber at the end. As we said, we require maintenance. We have to clean it up, and we have to clean the roller systems, some of them weekly, monthly. You see here at the bottom, they have these replenishing solution and the pump. So we put the solutions on the bottom and it will replenish itself. But then every week or so, or every month, we have to take these out, clean them up, and do all of that. Then it has to have a specific filtering compartment before it goes, before the water and the access fixer and developer goes into the sewer. So we have to have like an actual filter that will filter out any excess material and all of that. So again, there's a lot of things that going on with that. So we used to have, okay, we're almost there. To be able to process these films, we have to have a dark room. Again, we used to have a dark room when you go in with your films and then, be able to do the processing with your hand, or even to place the films inside of the processor, because you have to take them off the packet and to put the film into the processor. And if the film got exposed to any light or white light regularly, then it will be ruined. So what we can do is, again, make a dark room where you go in, close the door, and you have like a light similar to that. That is usually a red light, and that red light would be able to, again, you'll be able to safely work without having to expose your X-rays. So it has to be a light, tight room. The white color can blacken or fog the film, and we want to use a filter or safe light. Sorry, that's the red light. So that's called a safe light that we use inside of the dark room. And then if we want to do this outside of the dark room, we can have that mini dark room that we saw there in the slide, or a daylight loader for the automatic processor. This is what you see here. This is the daylight loader. So you put your hands through, and then you can open up the film packet and start loading it. So the automatic processor will connect directly to this, to the daylight loader. And then you put your films through the automatic processor without the need to go into a dark room. The mini dark room is the one that we saw here. Technically this thing here. And that's what we have. Any questions? No? Okay. Oh, yes. Where's my smiley face? Wait a second. No one leaves before my smiley face. Okay, I'm going to take my time. How about that smiley face? So happy. Yay, I'm done. There we go. That's your smiley face for today. Okay, keep a smile on your face. Enjoy the beautiful weather. Daniela, you did you talk to Miss Jukes? Okay, then wait for me. Let me just stop recording for a minute and